Okay, guys, this is going to be a repeat performance because apparently I didn't have the mic on when I did this lecture to the live class. So I'm going to kind of blast through this pretty quickly to go over all the high points, but basically we're going to work through this. I'm talking to a void classroom, so I can't have my interaction that I normally do. So we'll get through it. We'll get the high points here. And if you do have any questions, be sure to come talk to me about this because this is one of the most important aspects that we're going to do, right, with nursing. So as I said in lecture, we are ultimately responsible. The nurse is the one who is caring for the patient, the RN. We have people underneath us. We have LPNs. We have CNAs. We have PCTs. We have unit secretaries. We have a lot of people we can delegate to. So we have to make sure we're taking care of everybody. We're the ones that are ultimately responsible for the care of that patient. Physicians write orders. We follow orders. We listen to patients. We listen to patients' families. So we are the ones that are responsible because we're the hands-on person that's dealing with the patient. We also have to adhere to our standards of care. As you can see, we have three that we're talking about here. The National League of Nursing is the standards that the expectations that a faculty have to follow for nursing students to become novice nurses. We have to follow their standards in order for us to be able to be sure that you are competent as a novice nurse when you graduate. We just went through our accreditation program in February. Some of y'all know about that, and we were good. We're coming out of this well. We're following the standards, which is good. American Nurses Association gives us all of the things that we're supposed to do as nurses, as good, competent nurses across the board. That's at the national level. That's what we're looking at from a big overview point of view. The Nurse Practice Acts in each state will tell us what we can do at the state level. And then the Joint Commission, or that organization is basically setting standards for facilities. So when you're Joint Commission accredited, it's saying that facility is living up to the standards of the Joint Commission. And you're going to see that accreditation at a lot of facilities. If not Joint Commission, it's going to be the Department of Hospitals, Health and Hospitals in the state. So DHH is the other one. So standards of care are out there, and we have to deal with that. Competencies are the things that you have to be able to have proven that you can do the task that's being done. You guys have been checked off on vital signs, on catheter insertions, on med administration this semester. Next semester, y'all are going to be checked off on starting IVs, doing NG tubes, different things. So you're going to be able to be competent, deemed competent, by performing these tasks, and then we're going to go in, see one, do one, teach one. So you saw it done once, you did it on a mannequin or on another student, and then you enhance your ability to do this by doing it on patients then, okay? But from a competency standpoint right now, health and wellness promotion, that's what we're doing just in teaching the general public. Remember major concepts, we talked about health and wellness. Well, we're talking about that again, and it's going to be reiterated again. We're teaching people how to remain healthy, how to eat, how to exercise, how to be adherent to your medications, how to do the things to keep you going strong. Illness prevention is more at the clinic level, okay? So when I went in and I had the flu a couple weeks ago, the doctor and the nurse came out, the doctor told me this, but then the nurse reiterated it before I left. My discharge instructions were, go home, you're still infectious. You will be infectious until you are 24 hours fever-free, okay? So when I went home on Saturday, I was running 100.9 fever, okay? Sunday, when I woke up, my fever had broken, and I remained afebrile all day Sunday. And then Monday, when I woke up, I was afebrile, but I didn't come to work that day just to give it a little bit added insurance. So I was told illness prevention. I didn't want anyone else to get ill because of me. So illness prevention type of thing. Health restoration is more when you're in the hospital, okay? When we're bringing you back to health, we're giving you discharge instructions. When you go home, you need to take these medications. You need to give yourself this shot. You need to be able to come into the clinic to have different tests run, okay? Coumadin teaching, right? We need to do your INR every week. So health restoration is getting that patient back to a healthy lifestyle, hopefully the same lifestyle they had before they came in, and if not, teaching them how to be adherent to their new diet, to their new medical regime, whatever they may have there. Care for dying is pretty new to us. Palliative care, remember 100 years ago, if you got pneumonia, you died, okay? No antibiotics, okay? So as medications came along, as new machines came along, dialysis machines, people with chronic illnesses, insulin, the different insulins we can take now, people with chronic illnesses are now living. And they're living longer, okay? People who have been given a terminal diagnosis, cancer, HIV, something that we really can't get rid of, but a patient can live longer because of the interventions we have. So, you know, a patient who, once again, had stage 4 cancer, liver cancer, that metastasized, maybe, you know, a few years ago they would only live 6 months, 3 to 6 months. Now they may be living 1 to 2 years based off of chemotherapy, radiation, that type of thing. So palliative care, caring for the dying, that's an aspect of nursing that's relatively new, but it still is something that we need to be competent in. Okay, level entries of competency. This is demonstrating on nursing knowledge. As I told all of y'all, I keep reiterating to y'all, y'all know the answers. Y'all know what's going on. Your knowledge base is there. You got that in pre-nursing. It's your confidence that we're trying to bring out. We're trying to make you understand that you have the knowledge, just, you know, you need to now apply that knowledge to your care of your patient. So trying to increase your confidence with that knowledge base. See the words up there? Display confidence in the knowledge base. Your knowledge base is there, okay? Then you got to look at the roles. Right now, you're looking out at the units, and you got brown scrubs, blue scrubs, purple scrubs. You know, I mean, all kind of different roles on that unit. Knowing the roles of all the players out there, knowing their responsibilities, and then the functions of a nurse. Okay, so we are going to be teaching you that. You are going to be learning that over the next 3 semesters as you go through. What are the roles of each one of the people who are out here, and the different functionalities and responsibilities, and then what are our roles as a nurse? What's the Nurse Practice Act telling us we can do? And then recognizing our own limitations. Okay. And those limitations are, I'm going to be checked off. I checked you off for med administration. When you go in there, your hands are shaking now. You know, are you competent? Probably, but after you give your first shot, you'll be more competent, the second shot, the third shot, the fourth shot. Being able to do something that you haven't done in a while, you may go and do a catheter insertion. And then you may not see another catheter insertion the whole time you're in nursing school, okay? They just don't happen that often. So you get out, you're being precepted, and your preceptor says, oh, you got a catheter start, go do it. You may not feel comfortable with that. You haven't looked or seen a catheter insertion in a year and a half. Let them know. I really don't feel comfortable. Don't put your patient at risk. Know your own limitations. That's a big thing with competencies. Okay, Bender's stages of nursing, that's your box 42.3. These are the different things that you have to learn. Novice nurse is very structured. We tell you what to do. The instructors are going to tell you. You don't have latitude to make decisions to go and do things. Always check with your instructor to make sure that your instructor feels like you're competent enough to do it. So it's very autocratic, it's very much in control, and you need to make sure that you have checked with that instructor before you do anything. Advanced beginner is where you're going to start when you graduate in 3 semesters. You're going to be with a preceptor for 3, 6, 12 months, okay, depending on where you're working, okay? You need to learn different tasks. When I graduated, I had a competency booklet, 32 pages of check marks, check marks, check marks. I didn't get checked off on everything because even in a 12-week rotation that I had with a preceptor, we didn't get all of the things that needed to be done, okay? And that's okay. There's only so much time, and there's only so many times that some of these things are done. But at least I was checked off on 80 or 90% of the competencies that were needed for my job at that time. Competent nursing is 2 to 3 years. After you finish that preceptorship, in 2 to 3 years, you're going to be deemed competent. You're going to feel comfortable. When you walk on that unit, you're going to not own it, but you're going to feel, okay, I can handle most of the things that are coming at me. And if I can't handle it, I certainly know where to go to get help if I need help. Proficient is 3 to 5 years. When you're proficient, you're now walking on that unit and you're saying, you know, you might be a charge nurse now. You may be in charge of the code card. You may be having more, you're going to be having more responsibilities because you are proficient at what you're doing. In 5 years plus, that's where you're the expert. That's where they really can't throw anything at you that you haven't seen. You've seen everything pretty much after 5 years. That's a long road. That's a long thing that you got to go through. But it is, nonetheless, when you become an expert. You've received that expert rating. So, Bender's stages of nursing. Leadership, 28.2, table 28.2 tells you about the different types of leadership. Autocratic. Autocratic are people who, it's my way or the highway. Military type of leadership. You know, it's top down, okay? So what boss 1 says, boss 2 follows, boss 2 says, boss 3 follows, all the way down the ladder. It's top to bottom type of leadership, okay? Democratic is more, we're going to listen. Sometimes democratic is considered bottom to top. You know, the staff tells the manager, the charge nurse something, the charge nurse tells the manager goes up to the director of nursing, and things happen. So democratic is kind of bottom up. Laissez-faire is just more of a professional type of leader. You know, we're all professionals here. We all are competent. We all know what our levels are, and it's more or less a laid-back kind of attitude. But as long as you stay within the bounds of your professional latitudes, we're good to go. Laissez-faire. Bureaucratic, on the other hand, is somebody who is looking at a big picture, like a systems type of thing. Ochsner has 60 facilities. LCMC system has 5 facilities. So a bureaucratic leader is going to be at a higher level, could be administrative in a facility at main campus or UMC or at the hospital itself. but they're looking at the global picture. What's going on over the entire facility? What's going on over the entire system, okay? So they are going to be more bureaucratic. When I think of bureaucracies, I think of the government, the federal government, state governments, parish governments. Those are bureaucracies, okay? Same thing with the hierarchy of hospitals, okay? And usually the bureaucrats make the policies and procedures. And the expectation is that the other leaders will make sure that these policies and procedures are followed. Situational is going to be something that's kind of, it's not exclusive to nursing, but situational is what's happening at that time. So if there's a code, if there's a rapid response or something like that, you're going to be in a situational type of leadership. Someone's going to jump up and be a leader, a code white, a code blue. You're going to have one person who should be in charge, and they should be telling us what to do, okay? Now, these leadership roles in nursing kind of lend themselves a lot of times to different, either the situation or the units. Operating room better be autocratic. It can't be democratic and say, oh, we're running behind on our schedule, we don't need to clean the room. That can't be the case. We've got to be autocratic. We've got to follow the rules, top down. It's got to happen that way. Whereas in the emergency room, what do we see more of? The situational type of thing, right? You're going to have leadership, you're going to have things that are going on. There's going to be some democratic situations, but the leadership there is very situational because it's so fluid. It changes so quickly, okay? And then, you can have some types of leaders that demonstrate all of the above. I'm pretty laissez-faire when it comes to leadership. I think that everyone's a professional till you prove me wrong, okay? But when you prove me wrong, I'm going to probably go more to a democratic style and talk about how we can fix the problem, how we can fix the issue. And then if that doesn't work, then I'm going to become autocratic. It's going to come down the road. It's my way or the highway. So I've been in situations where I have had to bounce between all three different leadership styles, but it's something that needs to be done sometimes. So we just have to see what the situation is that we're looking at. All right, types of leadership is charismatic. This is the person who just looks the role. They walk on a unit, they carry themselves well, they speak well, they're very proficient, they're very competent, they're up on the literature, they know what's going on. People just, it's like a magnet, they just follow them. I don't, when you look and you say, well, why are you following this person? And once again, the best example is, Jesus was a charismatic leader, okay? He would walk through a city and people would follow him, okay? It's because he exuded this confidence. He exuded this ability. They may be humble. They may be, all of the good traits you would expect, but it's just something, a feeling that you have for a charismatic leader. We bounced around here. Our transactional leader on the other side of the coin is someone who is action-oriented. They take steps. They do things. They make things happen. So they come on that unit and they're worker bees. They get things done. They help organize the unit. They're able to, assist people. So you like these kind of people, right? Because they help you. They're transactional. They're action driven, okay? Transformational, on the other hand, are people who are risk takers. These guys come on a unit and they fix things, okay? They open new units. They organize things. They're able to take things that are going wrong and fix them. So if there's been a lot of falls on a unit, or there's been a lot of catheter-associated infections on a unit, they're able to take these incident reports, they're able to take these inefficiencies and make that unit better. They transform units, okay? shared, we're going to talk about shared from the standpoint that shared is everybody's on an equal footing, okay? And in a hospital, you have a lot of layers in a hospital, okay? And so physicians, nurses, pharmacists, all kind of different levels of competencies and different levels of expertise. In a shared type of environment, everybody's on the same platform. Everybody peer-to-peer kind of relationships. Shared governance is that type of leadership that you get when you get a magnet designation. 2 hospitals are magnet designated in the New Orleans area. The 2 hospitals are Ochsner Main Campus and East Jefferson Hospital. That's the only 2. And magnet designation is a step above Joint Commission and things like this. You have to jump through some extraordinary standards and hoops to be able to do that, such as you need to have a certain 80% of your bedside nurses have to be bachelor prepared. You know, you have to have a certain amount of master prepared directors and managers and things like that. Your ratios have to be within certain standards. So you can't have 7 patients to 1 nurse. You have to have proper staffing ratios. And this data that they're looking for covers, you know, like a 3 to 5 year period. So when you're applying for a magnet status, it doesn't happen overnight. You've got to gather this data. You have to show that you've maintained that level of proficiency through your hospital for a certain amount of time. Then they come in and they will audit all of the things and look at it and decide if they're going to give you that magnet recognition. It's pretty hard. A lot of people don't make it, as shown by there's only 2 facilities that have gotten that recognition so far in the New Orleans area. So effective leadership, box 28.1, you've got to have vision, okay? Any good leader and any good person who's out there has a vision for what they're going to do, what that unit's going to be like, what that hospital's going to be like, what's going to go on, what's their vision. Influence, if a leader doesn't have influence, it doesn't work, okay? Because as a staff, as a leader, you have to be able to be a change artist. You have to be able to take what your staff and your employees are telling you and making it a better environment for them. That's basically what leadership is all about, is being able to get these things taken care of. So if you go into a meeting with your supervisors and your other leaders of the hospital and you say, my staff needs to get this fixed, then that influence is something that you need to be able to be successful at that if you're going to remain a leader. If you constantly come back to your employees saying, oh, I couldn't get that done, I couldn't get this done, are they going to follow you? Absolutely not. They're looking to you to get things fixed. They're looking to you to get things taken care of. And then role model, okay? You're the one that should be there first. You're the one that should, you know, make the coffee in the morning. You're the one that people say, gosh, he looks like he's got it all together. He's seamless. When he comes to work, he helps. He does this, he does that. She does this, she does that. She's got it all together. She knows how to do her notes. She gets her assessments done on time. She gives her meds. She helps me. The other day they did this. So role models are what leaders are. They will be that way. Now, to be an effective leader, you know, you need to be able to have that vision, have that influence, and be able to have people say, you're a helper, you're here to get things done. So we're looking for effective leadership. That's what you're looking towards. So management levels, your first level managers are the people that are really kind of worker bees, okay? The one that comes to our first thought process is the charge nurse, right? They're in charge of 5 or 6 nurses, 2 or 3 PCTs, a unit secretary usually, and all the people who come on that unit are basically there. So we think of charge nurses, but think about rapid responses. They've got to be a leader there. Code blue teams, there's got to be a leader there. Code white teams, there's got to be a leader there. So leadership can be almost anywhere around. A senior staff member, someone who's very efficient, very competent, very expert in the field, they may be the nurse that all the other staff nurses go to help get things done. They're a leader, although they don't have a title behind their name, And I'll look at people too. I'll look at a unit secretary as a leader because they are bouncing around doing almost everything on that unit and keeping that unit held together. So you can have a designation, I'm a charge nurse, I'm a leader, or you can also be a leader just by example. Mid-level managers are the people above that unit. So that charge nurse is in charge of how many people? 10 people, 11 people, 15 people, something like that. Whereas the unit manager now has day shift, night shift, has 1, 2, 3 units. They make out the schedules. They handle people who are calling in. They manage that unit. They take care of the incident reports. How can I fix these falls? How can I fix these infection rates? How do I do this? These are your middle managers. They're going to handle those reports, those monthly reports that come out. Then you've got your upper level managers. These are more those bureaucrats. These are more the people that sit in the administrative offices. So the unit manager in mid-level is going to be on the floor, but not on patient care, hourly patient care. But they're going to look at things, they're going to take care of it. The upper level managers are in the administrative offices. They're going to be your vice presidents, your directors, and things like this. So they're going to be off of the unit, and they're going to be more hospital-wide and driven. So depending on the size of the hospital, you could have 1 director of nursing on a smaller facility, up to 3 or 4 vice presidents that are reporting up to the hierarchy. So these are more administrative types of people. What are their functions? They need to be organized. They need to organize everything unit-wise, room-wise sometimes, down at the lower level, at your first level, and then unit-wise and then hospital-wise. They've got to direct. They've got to be able to direct people and show them what's going on and what's needing and coordinating. So all of your managers have to organize, direct, and coordinate skills that are out there, people who are working. So look for those functions for your managers. All right, delegation is a very big thing. We delegate. We cannot take care of the patient totally and do everything that needs to be done 4 or 5 patients even if we're an expert nurse. We need help, okay? So we're going to delegate. So we as nurses delegate to LPNs, to PCTs, to dietary, to unit secretaries. We have a lot of people we can delegate. So we need to make sure that we're going to do the right task. So I could delegate some types of things to my unit secretary. The other day we needed to start a catheter, and to insert a catheter. There were no catheters on the unit. I could go to the unit secretary and say, I need a catheter. Can you go pick one up for me? Sure, I can go do that, okay? So it's a right task, right? They can do that, okay? And go to my PCT and say, Mr. Jones needs a bath in bed 5. They're competent. They can do that task. It's the right circumstance. It's the right person, okay? So we can do that. My LPNs, I can say, you know what, Mr. Jones has a PRN pain med, PO med, can you go give it to him? My LPN can go give them their PO meds. Now, LPNs cannot push any type of IV meds. So if that patient's getting a Demerol IV push, I can't say, go push this Demerol on this patient. RNs have got to go do that. So we got to know our Nurse Practice Act. We got to know if it's the right task, the right circumstance, the right person. And then we got to communicate. Okay, that CNA, that PCT may say, you know, Mr. Jones is a big boy. He's 350 pounds. I don't feel comfortable. Okay, they are telling me something. I need to listen, and I need to be able to say, okay, I hear you. Give me 15 minutes. We're going to go bathe him together. Come get me in 15 minutes. Let me go take care of a couple other things, and then we'll go do that. 9 times out of 10, what I have found in my practice is that person is not feeling competent. They're not feeling comfortable doing the thing I just asked them to do. When I go in there and help them do that task, when I go in there and help them bathe that patient, the next day I'm going to come in and I'm going to say, you know, Mr. Jones needs a bath, and guess what that's going to happen with that CNA? They're going to probably say, okay, no problem, Pete, everything's cool. We did okay yesterday. I can handle this by myself today. So right direction, communication, listening, right supervision. I went in there and helped them. And then evaluation, right? I mean, they came in, they said, I feel good about it. I can do it today, Pete. Okay, go do it. You know, they come out, how'd it go? Oh, it wasn't that bad. I was okay. Thanks for helping. Thanks for asking, whatever. Go on. I got to go in that room and look, okay? If I pick up that fold and I see excoriation, redness, some white stuff in there, some yeast, did it happen? You know, did they get cleaned properly or to the level of care that I expect? If it's no, then I have to make sure that I bring that person back in and we fix the problem. Because 9 times out of 10, once again, that CNA that went in there did the best they could. They just need to get more proficient at it, get more confident at the task. So right supervision, right evaluation. So 5 rights again: task, circumstance, person, direction. Remember that communication, 9 times out of 10, is our sentinel event. What is it? Sender, receiver, okay? So we send the message. We have to make sure we listen to what the person is telling us, okay? So sender, receiver. Make sure we've got everything together, that they understand things. Okay, our exemplar is prioritizing. So the big thing we're looking at is effectiveness, okay? How effective we are at carrying out a task. The next thing is efficiency. How efficient are we? And once again, as we do the task more and more and more, we become more efficient because we know how to do that task. And then the nursing process is what it's all about. You know, we're always assessing. What? Look what's up here. Assessment, box 36-4. Remember that assessment is our biggest thing that we're doing. We can't do anything as a nurse without assessing first. We need to look at that, and then we need to take into consideration that nursing process in prioritizing our care for our patient. So when we prioritize, we've always got to be effective. We've got to have good outcomes. We've got to be efficient. We can't take 3 hours to start an IV. We've got to get it done pretty quickly. And we've got to use the nursing process. We've got to figure out where we're going to do things, how we're going to do it after we do our assessment. So when we set priorities, table 3619 is going to give you some examples of each one of these priorities. A low priority is going to be a priority where the patient maybe needs a snack, maybe needs something to drink. It's a priority, but it's not something we got to drop what we're doing and take care of it. But make sure if we're aware of it that we give that patient a time frame. that we say, you know, Mr. Jones, I heard what you said. You want some crackers or whatever. I'm in the middle of doing something right now. Is it okay if I bring you your crackers in like 30 minutes? And usually the patient will say, sure, no problem. I'm okay with that. You know, but it's a low priority. It's on the back burner. Our medium priority is something that's a little bit more, the CNA comes out and says, you know, Mr. Jones needs a bath today. You know, he hadn't had his bath. Mr. Jones is not feeling too good right now. Well, what's going on? He's just complaining that, you know, he's just not feeling very well. So I'm going to go back in and reassess Mr. Jones. I'm going to go back in and talk to him. But based on the report I get from the person or from the patient, I'm going to say, I'll go in there in the next few minutes. Okay, so I bumped up my priority. It's something I'm going to go take care of this. I'm going to go give Mr. Pete his medicine over here because I already drew it up. I'm going to go give this Demerol shot, and then I'm going to go see what Mr. Jones wants. So it's a priority, but it's not something I got to jump on right away. I'm going to go in there and change a diaper, or I'm going to get Mr. Jones out of bed and put him on the potty. But you know, I'm gonna do it in a timely manner, maybe 5 minutes, maybe 10 minutes, or whatever, deeming, you know, what goes on after I assess the situation. But I'm going to have to assess it now because it's kind of a medium priority. But it can't be put on the back burner like the low priority. And then high priority is, Katie barred the door, I'm going straight in there. CNA comes out, blood pressure 200 over 100. Done. I'm in there. I'm checking it. I'm going to go and make sure that that blood pressure is what that CNA has. I'm going to go check my MAR. I'm going to make sure I have some PRN meds. I'm going to make sure that I pull those meds, I go give them to that patient. I don't give the meds automatically based off of what that CNA tells me. Can't do that. That's accepting someone else's assessment. I've got to know that. If I walk in there and give that med and don't assess that patient, and they bottom out and they drop to 60 over 40, what's probably happened? It's that reading that was done by the other person was incorrect. So before I'm going to give that med, I'm going to check it to be sure. That's just basic good nursing care, okay? So your different priorities. Time management, we all have issues with this. We've all got time constraints. Type A personality, right? 8:30 I'm going to be here, 9:30 I'm going to be there, 10:30 here. Boom, 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 boom. I got my day lined up. I got everything together. Things happen. Things are going to come up. So we got to look at urgency factors. 3622 gives you examples of different urgency factors. So they're pretty much what we talked about before. Non-acute, you know, is something that can be put off for 15, 20 minutes, an hour maybe. And then our acute situation is something that needs to be taken care of pretty quickly. But we can finish a task we're doing, but now we got to put everything else aside and go in and check that patient. But when we get to acute, it really needs at least an assessment and seeing what's going on. Critical and imminent death. Critical is I'm going to go in, check that patient, 200 over 100. I can leave the room because the patient's not in any imminent death situation, and go and check the MAR, go and pull a med, come back in and give a med to that patient. What's that take? That may take 5 minutes. That may take 10 minutes, depending on how things goes. But critical is taking care of it with the tools that I have at my fingertips right there. Imminent death is where I cannot leave that patient's bedside. I've got a situation that I'm in there. I need to be in there intervening with that patient and will not leave that bedside till that patient's stabilized. So if I call a code blue, or if I'm calling a rapid response, I'm the one that's in there taking care of them and making sure everything's okay. So I do not leave that room. Ranking in activities, activities are the things we're going to do for patients, okay? So table 3620 gives you examples of different activities and where they rank as far as priorities. So the priority 1 is I must do it, something I must do for that patient. Priority 2 is should do, something that should be done, and priority 3 is nice to do. So look at those examples, familiarize yourself with those different ones that are in the book. They're pretty good examples, and understand how you're going to prioritize. So the factors to consider, ethics. You know, we've already had our concept of ethics. Ethics is always out there. We are the most ethical profession that's out in the public. So we want to keep that high ethics. So whatever we make decisions, they need to be based in ethical considerations, okay? Safety, always paramount. Patient safety, patient safety. You'll see that drilled in over and over and over again. The resources, okay, just like I said, the example of the catheter kit. If we don't have the resources on our unit and we have a high priority incident that's occurring, we can run into issues, okay? The catheter kit wasn't necessarily a high priority. It was more like a medium priority. So we had the ability to go downstairs, pick up the catheter kit, come back to the unit, do the task that needed to be done. Whereas if this was a critical situation or an imminent death situation, and I needed to start an IV and I didn't have any kits on the unit, or I didn't have any normal saline, I needed to bolus the patient for some reason, then that's a problem. So resources are always an issue. We have to make sure our resources are there. Time management is definitely in there, right? But if we're a good nurse, we can change our gears, we can move around, we can take things into consideration and make sure our time is managed properly. Patient preferences. Always, always, always. When we're prioritizing care, let's find out if the patient's on the same page. Because I go in with my plan of care, right? Here's Pete Keller, here I am. We're going to do this at 7:15, 8 o'clock I'm going to do this, 9 o'clock we're going to do this, 9:30 this, 10:30 that. I got it in my head. I'm organized. I got it written down. I'm going to write it even on your little scribbly board here. We're going to tell you what's going on. Patient says 10 o'clock, I'll watch The Price is Right. Oh, well, I don't guess we can do your bath at 10 o'clock then, right? We're going to put that off. We're going to change it, okay? Any condition changes priorities, right? So as we're going through the day, patients' conditions change. Hourly rounding is a big deal now, and it's shown to work. It's shown that if we go in that room and we touch that patient every hour, look at them, talk to them, check in with them, our efficiency goes up tremendously. Our time management goes up tremendously. And it doesn't take long to check on our 5 patients. It may take 5 minutes, 10 minutes at the most. And then if we've just touched base with them and we've done this every hour on the hour, we're probably going to have put out a lot of fires that probably would have taken a lot longer had we not rounded in that room. So rounding every hour is a big deal, and looking for those changes in condition. And then we're always going to have the unexpected, right? Right in the middle of my documentation, I get the charge nurse. You get an admit in room 12, and I'm like, oh, let me just finish my notes. So I'm finishing up my notes. 10 minutes later, the charge nurse comes and says, your patient's in the room. Why didn't you call and get a report? I got to stop what I'm doing. I got to go in that room with that patient and do my admin assessment. And guess what? I didn't plan for that. It's unexpected. Those things are going to happen. Okay, pitfalls, prioritizing without assessments. Okay, This is a common occurrence with novice nurses. They get report. They got a competent nurse coming off the shift before. They get report. They figure out what they're going to do, and they just start doing stuff. They don't go in and check on things themselves. So always understand that before you start your prioritization of that patient, you want to be sure that you assess that patient and you know what's going on. Does it need to be a complete head to toe? No. But you need to go in there and touch base with that patient. You need to make sure they're awake, alert, and oriented. You need to make sure they're not in any pain. You need to make sure they're breathing okay. You need to make sure that things have been taken care of, that they've been given their bath. Because a lot of these things you get in a report that people say they did, you walk in that room and nothing's been done. And oh my God, you let it go and you're on the shift and you go in at 9 o'clock to give meds and the room's a shambles, the patient hasn't eaten, they're laying in dirty diapers. What's your day like now? You thought it started out bad, it's only gotten worse. So always get your assessment, see what's going on. Okay, incomplete assessments or when you don't ask the right questions and don't get enough information. Relying on another's assessment. We kind of talked about that. I kind of hit these before I press my buttons here, okay? Failing to do periodic reassessments. That's that hourly rounding. More and more literature is telling you that hourly rounding is working and working better and better as time goes on. So look for those types of things, those periodic reassessments, and do them. And box 36-7 gives you the things that are poor time management. Y'all will read that box and y'all will go, I don't do this, I don't do this. I do this, I do this, I don't do this, I don't do this. We all do some things that are poor from time management, but we want to get better. We want to do things a little bit better. So, just read it, understand it, know where your strong points are, where your weak points are. Because one of the first slides, right, was what are you good at? Okay, knowing your limitations and then not involving the patient. So many nurse ratchets out there that just walk in and say, bing, 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 bing. This is what we're doing, this is what we're doing, this is what we're doing. All of those things come into play. All of those things, and if that patient if it's not patient-centered care, we're not doing what we need to do as a nurse. It needs to be patient-centered care. And then inappropriate delegation. Like I said, you delegate that bath to the CNA. The CNA says they did it. You go back in and you evaluate, and it's not done to the level of competency or the way you want it done. What happens now? You have to give that bath. You have to take care of things. So, once again, your day has just turned south because you had an expectation that this was taken care of, okay? So, make sure that your delegation's appropriate, that it's being handled properly, and things are taken care of. Doing the easiest task first. This is one that novice nurses always get in trouble with. So the best example is the catheter insertion. Everybody, kind of doesn't like to do it. It takes time. You got to get the patient ready. You got to do a lot of things. 15, 20 minutes to do this. Wow, it's something that's got to, So, I can go bathe a patient. I can go feed a patient. I can go give meds. Those are easy. I like doing that, okay? I don't like putting that catheter in. I'm going to put that off, put that off, put that off. The worst thing in the world is to put it off because I don't know how many times I've come on a shift, order was written 6 hours ago, 7 hours ago, and that nurse put it off, put it off, put it off. It's shift change. Oh, by the way, in shift, we gotta do a catheter insertion. It's like, okay, no problem. I can take care of that. That's on what bed? Okay, we got that. my assumption is that that nurse got that order a half hour ago, you know, right before the shift ended. But in reality, they got that order 5 or 6 hours ago. I go in that room, I'm doing an assessment, I see a suprapubic area that looks like they have a 9-month baby in there, okay? That poor patient has been laying there not being able to pee for 6 hours, okay? So where does that move up in my priority? Normally it's a medium priority kind of a deal, but now it becomes a critical priority to me. My shift's not starting right, okay? So try not to fall into that black hole. It's not easy and it happens a lot. That's it. So hope y'all enjoy your weekend. Have a good time. And I'll see y'all next week.